Digital Solutions to Support Care Transitions Challenge Overview webinar. This webinar is going to be recorded today, and the recording of the webinar and the deck will be made available on AHRQ's website after the webinar today. So, today's agenda, we're going to cover two main areas. First, we're going to break down the themes of the challenge. We've got an excellent expert panel to speak on the various topics that this challenge covers. And then we'll look at challenge logistics, the criteria for submission and evaluation, and the submission process. After that, we'll have a Q&A session, time for questions and answers. So to quickly look at the challenge purpose, and this comes from the challenge website. We hope you all have had a chance to view it. We will go over there briefly when we look at the submission process. The goal here is for solvers to propose and develop interoperable solutions that engage patients and caregivers during healthcare transitions. And this challenge specifically is looking at the transition from hospital to home. The solutions proposed and developed should aim to reduce administrative burden and information management burdens, and they should support patient engagement and activation. Lastly, the solutions should be developed using user-centered design to improve care communications during transitions. And they should demonstrate interoperability features in and with electronic health records. And we will touch, so these are all the things that we will go into more deeply in this challenge. So with that, we'd like to dive into our first challenge theme, and that is care transitions. With us to speak about the theme is Priscilla Novak. She's a program analyst in the Office of the Director here at the Agency for Healthcare Research and Quality, AHRQ, which is our challenge sponsor. So Priscilla.
Good afternoon, and thank you for joining us. Can everyone hear me okay?
Yes, we can.
Okay, thanks so much. So the first topic that we're going to talk about today is care transitions and provide an overview of that topic. This challenge focuses on hospital-to-home care transitions, essentially on communicating hospital discharge instructions and linkages for people to access community resources, receive, understand, know their medication regimen and the instructions for taking their medications, and being able to track, monitor, and adjust follow-up appointments. Typically, what we see is that when patients are admitted to the hospital, they're admitted for treatment of one specific issue, and the care plan that they are given, or their discharge instructions, are specific to how to manage that one particular condition post-discharge, and it may not address the other health issues that people deal with. However, people with multiple chronic conditions in their families have to manage all of their conditions. So they might have clear instructions about one particular part of their health status, but not have as clear of information about the other conditions that they're also trying to manage. So for purposes of this challenge, care transitions are transfers from an inpatient setting where there are a lot of professionals helping the patient and their family and caregivers with their needs, to being back home. And once they're back home or in a residential setting, patients, families, and caregivers once again have to work across their multiple providers and coordinate their own care. While there might be some people who come and help them with their needs, like a visiting nurse or a physical therapist, it might be a different set of people than who they had in the hospital, and most likely is. And then they might be going back to different healthcare providers than those that were overseeing their care while they were admitted to the hospital. What we do know is that frequently there are communication breakdowns between hospitals, patients, families and caregivers, and primary care providers. So when a patient is discharged from a hospital, there is often a lag time where the discharge information or the care plan does not reach that patient's primary care provider or healthcare provider. In addition, many people with multiple chronic conditions have to see more than one provider. So they need to transmit the information. There's a need for that information to be shared, not just with one single internal medicine specialist or pediatrician and primary care provider, but also with other specialists who might be responsible for different aspects of the patient care. Patients need this information, patients and their families need this information so that they know what medications they're supposed to be taking or receiving. They need to know what appointments they're supposed to attend and who they might need to have be there with them to understand and communicate with the provider. And then there might also be new healthcare issues that they're having to cope with and respond to in addition to the ones that they were originally dealing with before their hospital admission. So most of the issues in communication of information arise in communicating what happened in the hospital and what the care plan is for the patient at home. Can you move to the next slide, please? Currently, many electronic health records do not enable seamless information transmission from the hospital setting to the patient's regular healthcare team. And so this challenge is about how information can be transferred from the hospital to the patient and their healthcare delivery team so that everyone has access to the information that they need for appropriate follow-up. There is a need to address the people, processes, and technologies to send and receive care plans and optimize medication reconciliation. And digital care plans need to be accessible to the various providers that care for a patient, especially for people with multiple chronic conditions. So winning solutions in this challenge would enable patients, families, and caregivers to receive and understand hospital discharge instructions and care plans while easing administrative burdens on physicians, nurses, and staff at discharging hospitals. On the next slide, we see some of the AHRQ resources that are already in existence, and these include our health literacy toolkit. We have a medication at transitions and clinical handoffs toolkit for medication reconciliation. We also have a toolkit on re-engineering the discharge process. Furthermore, we have a toolkit on transitioning newborns from NICU to home. So these tools cover a variety of the different specific challenges that patients might encounter in care transitions, and they're available on our website, and we would encourage them to use them if it's applicable to your project. And now I'd like to turn it over to the next speaker, Dawn Wiest. Jamie, will you be providing an introduction?
Sure. So Dr. Wiest is the Director of Research and Evaluation. First of all, sorry, thank you, Priscilla. That was very great to start off with care transitions. Dr. Wiest is the Director of Research and Evaluation at the Camden Coalition of Healthcare Providers. So Dr. Wiest?
Hi, everybody, and thank you, Jamie, for the introduction, and Priscilla for that excellent introduction to the challenge. I am going to be talking a bit more about multiple chronic conditions and some of the challenges that multiple chronic conditions present for care coordination and care transitions. And I want to check in with everybody because I am calling in from Camden in our building here, and we have very thin walls, and there are a couple of meetings going on alongside me, so hopefully the background noise isn't too bad. So according to data published by AHRQ, around 1/2 of people in the United States between the ages of 45 and 64, and around 80% of people aged 65 and older have 2 or more physical or behavioral health chronic conditions. The growing prevalence of multiple chronic conditions is a high priority public health issue, especially given the toll that chronic illness takes on individual patients, their families, and the healthcare teams that support patient management of multiple chronic conditions, as well as the costs associated with treatment. A current estimate is that treatment for people living with multiple chronic conditions accounts for roughly 2/3 of healthcare costs in the country. And because patients with multiple chronic conditions frequently rely on hospital-based care, most of the direct costs of treating these can be attributed to emergency department use and hospital admissions, especially for chronic conditions such as congestive heart failure, chronic obstructive pulmonary disease, commonly known as COPD, or diabetes. Frequent hospital use is often seen as an indicator of the quality and efficacy of ambulatory care in the community. A significant proportion of emergency department visits and hospitalizations for chronic illnesses could be prevented with proper ambulatory care facilitated by timely and appropriate care transitions from inpatient hospital care to home, which underscores the timeliness and importance of the current AHRQ challenge. So there are many possibilities for how chronic diseases can co-occur, and I've included just a few examples of some high prevalence combinations on the slide. And maybe going beyond these examples for a bit, thinking about Medicare patients, for example, research has found that some of the most common co-occurring chronic diseases among Medicare patients of all ages is hypertension and hyperlipidemia. And among younger Medicare patients, diabetes, hypertension, and hyperlipidemia often co-occur. And as another example, one of the most common chronic condition co-occurrences among older Medicare patients is ischemic heart disease, hypertension, and hyperlipidemia. And further and important to consider, and I'm going to talk a bit more about this in a couple of minutes, in efforts to improve care transitions for people with multiple chronic conditions, is that individuals with chronic mental health conditions such as depression have an increased risk of other medical chronic conditions such as cardiovascular disease and diabetes, and vice versa. And this combination of mental health or other behavioral health chronic conditions with physical chronic conditions presents very specific challenges that I'll talk about in a bit that I think are incredibly important to consider when thinking about digital solutions for improving care transitions for people living with multiple chronic conditions. So when the number and complexity of chronic illnesses a person experiences increases, the challenges to care management, care coordination, and planning, and most importantly, the quality of life for people living with chronic illness and their caregivers escalate. Fragmentation is a significant concern here, as our healthcare system remains largely specific disease or condition oriented, as Priscilla described, while understanding and supporting the patient's ability to manage their coexisting conditions requires a more holistic perspective, including an understanding of what matters most to patients and what their challenges and barriers to health are. In the move towards value-based care, and understanding of what the patient is willing and able to do for their health is critical, and I think is a very critical concern when thinking about digital solutions for care transitions for people living with multiple chronic conditions. So eliciting information from the patient and making sure that this information not only travels with them, but is understood and honored by community-based providers is essential. Ensuring a holistic approach to care becomes more complicated when a patient's health is co-managed by diverse providers in the community, including specialist physicians whose care recommendations are governed by distinct clinical guidelines that may conflict with those of other providers involved in a patient's care, and importantly, who are not often involved in discussions with the patient and their primary care provider. In such situations, the treatment burden experienced by the patient, their family, and the caregivers, and the risk of harm to the patient rises. So the challenges of managing complex health issues for people living with multiple chronic conditions grow even further when we think about social and structural factors that can constrain a person's ability to access quality care in the community and self-manage their health. Socioeconomic status hinders a person's ability to pay for clinical treatment and to afford all of the things that are essential to the success of a treatment plan. For example, reliable transportation to and from appointments, medication, healthy food. Other social factors that can severely constrain a person's ability to adhere to the best laid treatment plans and the best care coordination efforts, such as literacy and language barriers, social isolation, trauma, criminal justice involvement, immigration status, housing instability, and homelessness, to name just a few, must be considered in care transition and management planning for people with multiple chronic conditions. Without an understanding of these sociostructural barriers that people living with multiple chronic conditions might be experiencing, the barriers to care and well-being, without taking these into consideration and understanding them and having a plan for addressing these upon hospital discharge, even the most seamless communication between hospital-based teams and ambulatory care providers about an individual's medical needs, although necessary, is not sufficient for improving outcomes for complex patients. For patients with complex health and social needs, a cross-sector approach to care transitions and management may be essential. So mental health and substance use related conditions combined with physical chronic conditions also pose very specific challenges to efforts to improve care transitions from hospital to home. The co-occurrence of a mental health disorder with multiple chronic conditions has been associated with increased reliance on hospitals for healthcare when compared to individuals with multiple chronic conditions alone. In the United States, individuals with mental illness have higher mortality rates than the general population. But, and this is important to consider here, while certain behavioral health diagnoses do have higher mortality rates, such as psychosis, certain mood disorders, patients tend to die from the same chronic health conditions as the rest of the population, not from mental illness. And this underscores how critical it is that a holistic view of a person's health is represented in any care transition plan that is transmitted from the hospital to community-based providers or shared among community-based providers. Research suggests that older people living with multiple chronic conditions combined with mental health issues are at the greatest risk for having needs that are not met in the community after hospitalization. For example, adults with conditions such as depression, anxiety, or phobias experience many difficulties accessing specialty care that they need in the community. In research that we published here at the Camden Coalition last year, we found that while nearly all of the individuals enrolled in our care management intervention for patients with complex health and social needs had seen their primary care provider within a year of enrollment in the intervention, only 17% who had active mental health conditions had also been seen by a behavioral health provider in the community to address their mental health needs, again underscoring the need for this holistic understanding of a patient's needs, especially those living with multiple chronic conditions combined with mental health issues, and ensuring that communication travels with the patient to providers in the community. So if you go to the next slide, please. The slide here is mostly just a summary slide of additional points that are related to what I just shared, points to keep in mind when designing digital solutions to care transition challenges for people living with multiple chronic conditions. Given increasing workloads faced by many care providers, it's important to think of solutions that ease provider burden rather than add to it, as was mentioned at the beginning of this of the webinar. This is an important consideration, particularly when thinking about the need for more of a cross-system approach to care transitions for people living with multiple chronic conditions and behavioral health needs, and where sociostructural or cultural barriers impede access to quality care and complicate self-management of chronic illness. So facilitating the flow of information is a great and important step, but part of that has to be ensuring, as far as possible, that the information shared is actionable. In other words, that the recipient of the information is empowered to act on it. And this is really where co-design comes into play in a powerful way when thinking about these digital solutions for care to address care transition challenges. So thank you for listening, and I hope this information is helpful to you as you think through how best to address challenges related to care transitions for people living with multiple chronic conditions. On the next slide, I've provided some resources to give you more information. Most of these are academic resources, really helpful for getting a more in-depth understanding of multiple chronic conditions from the perspective of people living with them, from the perspective of healthcare providers, and the relationship between multiple chronic conditions, chronic illness in general, and to social determinants, as they're commonly called, or social structural factors. Thank you.
Thank you very much, Dr. Wiest. So also here to share some additional perspective on multiple chronic conditions is Dr. Anand Parekh. Dr. Parekh is the Chief Medical Advisor at the Bipartisan Policy Center. Dr. Parekh? Make sure you're not muted. Oh, you may have fallen off. There we go.
Great. Can you hear me now?
Yes, we can. Thanks.
Okay. Great. Well, it's an honor to be on this webcast with all of you, and I probably want to be pretty brief here and just share a couple of thoughts. I think the speakers before me laid out the challenge very well and provided, I think, the sufficient background information. I had the opportunity when I was at Health and Human Services to work really closely with AHRQ for over 10 years, and during that time, in 2010, we launched the strategic framework on multiple chronic conditions, which essentially was our roadmap to figure out how do you improve the quality of life and health status of this population. And that framework was a public-private partnership with a series of goals, objectives, and strategies that spanned delivery payment reform, supporting individuals with self-care management, equipping healthcare professionals to take care of the multiple chronic condition population, as well as enhancing research. And it is great to see the continued interest focus on this population. I also had the opportunity to focus on the care transitions work that the department led and AHRQ was involved in over the last many years as well, particularly care transitions focusing on hospital to home and preventing potentially preventable hospital readmissions. And we have seen some progress in that area over the last few years. But the two concepts here, multiple chronic conditions and care transitions, go hand in hand because that is the very population that is vulnerable during times of transition. In fact, for the Medicare population, virtually all hospital 30-day readmissions are in the population with multiple chronic conditions. In fact, over 4 out of 5, 81%, are in the population with 6 or more concurrent chronic conditions. And so I think tying these two are incredibly important. I will just say from a population health perspective, I mean, some of this data has already been covered, but there's tremendous prevalence of multiple chronic conditions in the population. Of course, it's a very heterogeneous population as well, so we're lumping in a lot of people at one time, and I think that that's important as you design your strategies and digital solutions to enhance care transitions. People with multiple chronic conditions in the United States differ in many aspects, whether it's, of course, the number of conditions they have, the combination of conditions they have, whether they have limitations in activities of daily living, as you've heard, whether they have social needs, whether they have insurance, and then, of course, they have varying degrees of health literacy, and that is obviously a focus also of AHRQ's work here. You heard about, for particular populations such as Medicaid beneficiaries with MCC, how important it is to take into account behavioral health concurrent conditions. For the Medicare population, critically important to take into account activities of daily living. So understanding sort of the heterogeneity of the multiple chronic condition population and designing and matching specific digital tools to help specific subsets of the multiple chronic condition population, I think, will be critical. What we learned in terms of sort of care transitions, particularly for Medicare beneficiaries in our work to try to reduce potentially preventable hospital readmissions, was that essentially about a quarter or about 30% of 30-day hospital readmissions, again, that's just one outcome measure to look at, are in fact preventable. And from a communication perspective, where things fall through the cracks, it's really at the level of not fully understanding discharge instructions, not doing sufficient medication reconciliation, and not ensuring that there is follow-up in terms of outpatient appointments. And so really honing in on those three levels, the understanding of discharge information, the Medicaid reconciliation, the follow-up appointment being critical in a timely manner. Those are all potential avenues where you could focus your tools to enhance communication and to enhance sort of care transitions. As has already been talked about by the speakers, there's a tremendous array of drug-disease, and disease-disease interactions when it comes to the multiple chronic condition population. And so the complexity there is something that makes it challenging, but that is sort of the very reason why sort of digital tools and ensuring good communication between the provider as well as patients and their caregivers can go a long way to improving health outcomes and reducing preventable healthcare utilization. So, James, maybe I'll just stop there, but thanks so much, and looking forward to participating in the discussion and question answer.
Thank you so much, Dr. Parekh. That was great. And yes, there will be time for questions toward the end. We're going to take a kind of a shift in content now. Everything we've covered so far has been kind of laying an excellent groundwork for not just what the problem is that AHRQ is trying to accelerate solutions to, but also who we're solving this problem for, the patients, the providers, and really what that problem consists of. It's not only that it's hard to transition people with multiple chronic conditions from hospital to home, but why? And that's this information breakdown, people slipping through the cracks, this lack of a holistic view. So hopefully everyone has laid out a great framework there, and now we're going to shift into more content about what solutions should look like, how solutions should be designed, what the methods should be for going after a good solution to this. So I'd like now to introduce Maia Long from the U.S. Department of Health and Human Services. Maia is the Senior Business Consultant in the Office of the Chief Technology Officer, and she's here to discuss digital solutions and user-centered design. Maia? Looks like her microphone.
She's not muted.
Not muted. Her microphone may not be connected. Just messaging her.
Can you hear me now? Oh, this might be it.
Yes, we can. Yes, we can.
This is great. I love technology. This is wonderful. Good afternoon, everyone. Just quickly, sorry, my last name is Laing, L-A-I-N-G. It's a pleasure. No worries to anyone. It's a pleasure to participate in this call today. I'm very excited to talk about digital solutions and how we apply user-centered design in identifying new healthcare technologies. You can move to the next slide. Thanks. Just a little bit about myself. Over the past year, 2 years, I've been working with Indian Health Service on their health information technology modernization effort. Why that's relevant is that through that experience, we have been looking at how can we be forward-leaning as we think about health IT and the solutions that we bring to Indian Health Service here at the department. I've also had experience working in healthcare delivery at Brigham and Women's Hospital in Boston, and have seen the opportunities that technology has afforded in delivering care. But more importantly, the question is, how do we align the technology to the needs of our patients and the care providers that are in those environments? And so today, there's a number of different digital health solutions that we are beginning to see. There's certainly apps that we see on phones. Many people now, through meaningful use, are seeing patient portals. and being able to access their medical records or components of their medical records, as well as communicating with their providers and care teams through these patient portals. These are examples, really good examples of how digital health solutions are closing gaps for patients to be able to engage with their care team and make decisions about their care. A lot of digital solutions to date don't allow the patient to sit in the driver's seat. A lot of the innovation that we've created through electronic health records support the workflow and billing needs of healthcare organizations. Oftentimes, these create gaps for patients, and many patients still struggle to navigate the healthcare system. There's a lot more interest in empowering patients with their own data and thinking through what types of solutions enable patients to be more engaged. The way that we think about identifying these new solutions and developing them is looking at what patients need in their care experience. And you may have heard about this in a number of different ways: user-centered design, human-centered design. Um, the goal is to put the patient at the center of what we're solutioning for and begin to develop technology that aligns to their needs. What's important to note there is that it's not about me as one patient defining what everyone else needs, and that's oftentimes what we see happening. What we want to do is apply user-centered design, and by that I mean we want to engage with multiple users, or in this case, multiple patients, to get a deep understanding of the problem framed from their perspective. And so we like to collect and do a number of interviews, and based off of that, we synthesize into having what is called a persona of a patient. And it's a culmination of a number of different statements that become similar through that engagement, and then we define that persona. And we build out what that journey looks like for that patient, whether how it looks in its current state or how we imagine it could look in the future state. And we design tools and new solutions based off of that patient's need, as opposed to maybe a developer or just someone who has an understanding of the problem finding those requirements. We want to establish and validate those requirements through having a firm understanding of the patient's needs. And so we want to be able to ask ourselves, who are we solving the problem for? We want to make sure that we're engaging and validating that problem through the patient. It should not just be one conversation, there should be multiple conversations. And then we want to make sure that we continue to engage the patient and who we are solving the problem for as we design the solutions that we need. Moving, next slide, please. Great. So a lot of the standards that we like to see when designing new solutions, and some of these things may not sound new to you, is that one, we like to use a human-centered design approach. Again, validating that the problem is anchored in the patient expressing their need or the user expressing their need. We want to apply agile development methodologies. We do not want to, I guess, put all of our eggs in one basket, right? We want to kind of apply one egg at a time until the basket becomes full. And the reason for that is that we don't want to overinvest in the development of something that doesn't align to that patient or that user's needs. And this is why we want to continuously have user-centered design as a part of the process. We like to apply open source as much as possible and ensure that we are also developing solutions that are interoperable. I love that there was a time, for example, with cell phones that, you could only talk to the people who had AT&T as long as you had AT&T. And the people who had a Verizon cell phone plan, you could talk to them. And there was a different charge to talk between AT&T and Verizon, right? So we want to see solutions that have less friction, right? And there's a greater opportunity for information to flow between different technologies, and that's very important. Oftentimes, we like to see things that commit to the broad community and advancement of the community broadly by using open source development, which allows many people to come in and iterate on what's been developed. We want to take a look at the landscape in different environments as we look at solutions. I'm based in DC, but an example with Indian Health Service is that it's a rural care delivery model. And when we think about solutions, we need to think about the demographics of the people that we're solving for, and recognizing that people under different situations or constraints may need different types of solutions. And so we want to be very clear in understanding that landscape and assessment. We Historically, the electronic health record has been, and I mentioned this already, driven by the operational needs of the hospital, the workflow, and the need to bill. We need to make sure that we put individuals that are utilizing the technology at the core of what we do. We need to see a lot more solutions that interact with each other. Again, APIs is a great way of thinking about that. There's different standards that can be applied, whether they're FHIR, thinking about HL7. We want to look at solutions that close gaps. An example of that is telehealth. Those telepharmacy patients are all over the place. They have different schedules. They may not have immediate access to facilities. We want to think about technologies that begin to close the gaps in access to ensure that people are getting the care that they need. When we look forward in healthcare and we think about technology and digital solutions, we want to see that the patient is in a position of control and is able to drive their healthcare. And this is challenging today because the healthcare system is very difficult to navigate. But just drawing off of applying user-centered design, the healthcare system exists in order to support the patient. And it should not feel like a black hole or a nebulous type of environment to interact with. We want to be able to empower the patient with their records, empower the patient with tools that allow them to make decisions about their care, and give them the information that they need at the right time. And so I think that is it. Is there another slide? I think that's it for me. Yep. So what I have shared here is a link to some of the work we've done with human-centered design and health information technology for Indian Health Service. This link will give you access to even more examples of personas and journey maps and how we applied this method to understand where the opportunities for health information technology exist. I think this is a great way of framing and thinking through how you're going to identify a product or a solution that you want to build on, and we want to anchor that in human-centered design early on in the problem formation. So thank you.
Thank you so much, Maya. And again, apologies about the name. I'll make sure that we get that corrected when the slides get distributed.
Yeah, no worries. Thank you so much.
So we're going to talk now a little bit about interoperability. Interoperability is an underpinning of this challenge, and at its core, it is the path of least resistance, allowing one system to send and receive information to and with another. With regard to electronic health records, that means FHIR. That is Fast Healthcare Interoperability Resources. Established by HL7, FHIR is a data structuring standard that is used in 84% of hospitals as of 2019. You can see here the various entities outside of hospitals currently using FHIR. When we talk about interoperability with regard to this challenge and digital solutions, we're talking about access. Maia talked about exploring the full landscape of environments in which solutions need to be implemented. The more interoperable your solution, the more system agnostic it is, and the more ready it is to interact with existing systems today and new systems tomorrow. So you can see here some of the descriptors of FHIR, but FHIR is essentially a tagging standard. So if you're familiar with XML or JSON or even HTML, the concept is not new. Within the code that carries EMR data, a set of bounding tags exist around each piece of information stating what it is. So you can kind of think of it like receiving a package in the mail. If the box is well marked and you know from exactly which vendor it was sent, then you know what you're expecting when you open that box. But if it's unmarked and ambiguous, you're not sure what to expect or how you'll react when you open it. Implementing FHIR ensures that the data are packaged in a nice, clear way so that the receiving system knows exactly what to expect. So you see here what makes up FHIR. The fact is there's a ton of information out there. HL7 has done a great job documenting FHIR, and there are huge communities to learn from. So we've documented those resources here. And as mentioned, the deck and the recording will be available after the webinar, so you can easily get to these resources. Lots of communities with support. You can ask questions. You can see all the questions that you probably have already been answered. And as you research FHIR, you'll see how generally accepted it is. But one more thing to close out interoperability is to stress how important it is to this challenge. This challenge focuses on patients and providers and the barriers to comprehensive care. Those barriers usually coincide with additional ones, often technological or geographic. Designing your solutions to the FHIR standard not only increases the likelihood that your solution will integrate with other systems, it grows your opportunities because having the standard in place adds several dimensions to the extensibility of your solution. So with that, we've covered the challenge themes. We're going to go into more logistic pieces, talk about submitting, submission requirements and evaluation criteria. And then we'll go into a quick demo of how to submit your solution before we get to the questions and answers. So looking at prize structure and timeline, this is a phase challenge. Phase 1 is open and closes April 6th. There are up to 5 phase 1 winners will be picked. And phase 2, which is focused on development and testing of your solutions, kicks off in May and will run through October. Phase 1 winners will present their work, the work they did over phase 2, as well as findings and plans. And ultimately, 2 challenge winners will be selected and announced in November. So the submission requirements. Here's where we get into what it is that AHRQ is asking you to submit. So we are asking for a description of the needs your solution aims to solve. We're asking for what your solution is and how you plan to implement it. So as far as exactly what that document should be, it's a narrative, and it shouldn't be more than 5 pages. The description of submission requirements are covered here over 2 slides. So I'm just going to go through these bolded elements here. So we want to hear about your solution, how you're using user-centered design, the plan to reduce burden, addressing various levels of health literacy. This was covered early on in the challenge purpose. Talk about the platform that your solution will live on, development structure, operating system, capabilities. And this can include how you're using standards, your usability, how you will address usability. That's a major component, especially in user-centered design, and how you'll protect privacy and security of patient data. Additionally, we'd like to see a work plan for how you'll build out the proposed tool if you're selected for phase 2. And then there's room for appendices. So in addition to the 5 pages, and there are 3 types of appendices: a description of your project team, reports and data sources, images, wireframes, diagrams, flowcharts. Lastly, you'll have the option to include a link to a video, 2 to 3 minutes, in your narrative, a video that you've published. Please be sure to review the AHRQ video guidelines before submitting your video. And that the video submission is optional. Next, we'll jump into evaluation criteria. So you all can read this. This is all from the website, so I'm not going to spend a lot of time covering this. Just want to pull out some key points. Understanding of the problem and user-centered design. So the focus here is on the methodology to develop the tool. So, if you research user-centered design and what those project formats look like, you'll learn about customer discovery, consistent interviewing, iterative development release, feedback loops, and development again. These are important factors in how you develop your solution and how you frame that in your submission to this challenge. Proposal to address needs of patients and providers. So this is the largest section in terms of evaluation weight. And I want to call out this in the first sentence here. Proposal addresses information needed for successful care transitions for people with multiple chronic conditions. To successfully convey that, you first need to know what a successful transition looks like. And in that scenario, a patient with multiple chronic conditions, in order for you to describe how your solution addresses the information needs. So these evaluation criteria are well thought out, and so they're comprehensive, and they are what scoring will be based on for the submissions that come in. So we recommend careful review of them. So also here, talking about the usability for your primary stakeholder. How innovative is your solution? So how do you set yourself apart from similar solutions? And then how do you tailor it to those with low health literacy, limited English language proficiency, and culturally, linguistically, and technologically diverse audiences? And lastly, your plan. So discuss the design of your solution, your use of standards, privacy, integration into current workflows. This is difficult and big in healthcare. And then if you're selected for phase 2, what your plan, your development plan for looks like. And lastly, open source versioning of the tool, if possible. And with that, I'm going to jump to the submission process. So in the slides here, you see static images because the slides will be sent out, and this is a static guide for you all to use. But I'm going to actually jump over now to the AHRQ website, which hopefully you all are familiar with. Lots of information, even more information here. Additional links to literature. So when we go to how to enter the challenge, you see here you can view the AHRQ video guidelines down at the bottom here. These are your submission requirements. And when you're ready to submit, we'll go to the online platform to bring you to our challenge platform. It'll bring you directly to this challenge. And you can click join the challenge, and it'll ask you to log in or sign up. You can log in using common social media, Amazon, create your account. I've already created an account, and so I'm going to log in. It's going to ask me if I want to join this challenge as an individual or as a team. I want to join individually. And then I can view even more information about the challenge. You can view all of this information without joining it. You can view about the phases. We will be posting frequently asked questions after the webinar. You can view information on the rules. Now, this information is available in the challenge platform, but for reference, for system of reference, please always go to the AHRQ challenge website, which we showed you before. So to submit, we go to submissions. So we click submit solution. We put in a title for our submission. Grab a file here. And we're looking for doc files or PDFs, preferably. You can upload that. And when you're ready to submit, submit. It's as simple as that. You can withdraw your most recent submission. If you do have multiple submissions, the system looks at the most recent one as the current submission. You can also download a copy of it if you need to. And that is it for the demo and for the bulk of the webinar. So we're going to jump back now and take some questions. You all can submit questions through WebEx. There's a Q&A pod there for you. It looks like we already have a few. And at some point, maybe once we get through these, we can open up the microphones. We can unmute everyone and take questions over the phone as well. So jumping into the first question, is, how about the reverse? And I believe this was asked early on in the webinar, and that is reverse of the situation from the hospital to home transition. So the question is ambulatory admission from home. It's a big problem for ED staff to obtain the most recent subspecialty visit notes. If on oxygen, for example, what's a typical setting, and where in the chart the plan is, or the pain plan. So for example, with sickle cell. I think I would ask Priscilla to possibly chime in on this one in terms of the focus of this challenge. And I'll lead into handing it over to Priscilla by saying the focus of this challenge is specifically hospital to home transitions for patients with multiple chronic conditions. But Priscilla, did you have anything you wanted to add?
I had a little bit of difficulty hearing what you said the question was, but I heard about oxygen as well as pain management for people. I think the oxygen was for separate patient profile, like someone with COPD, and then perhaps the pain was for someone with sickle cell.
Well, it was more about that. I think that was an example. It was more about the reverse transition, so from a home or to ambulatory care. It was more about, I think the question is whether that can be covered in this challenge, because that's also a big problem.
So I think the focus is on the flow of information when someone is discharged out of the hospital to home. Normally there would be follow-up in an ambulatory setting. So the information would need to be transferred not just from the hospital to a patient, but also to the full healthcare team or social services team that supports that patient. So whether it's directly to the patient and their family and caregivers, or to the patient's care team of office-based care, physical therapy, Meals on Wheels, how to make the information flow and go where it needs to be so that people can get the care that they need once they're discharged from the hospital.
Great. The next question, what are best practices if organizations may have heavily invested in an EMR EHR with suboptimal patient-facing portals or digital solutions? Priscilla, do you have thoughts on that, or do any?
Can you repeat the question?
Sure. What are and Priscilla, I look to you for a lot of these. I also welcome our panelists to jump in with thoughts. What are the best practices if organizations may have heavily invested in an EMR EHR with suboptimal patient-facing portals or digital solutions?
I'm not entirely clear on what the question is getting at. If they're asking if we know of suboptimal practices that should be avoided.
So I think so. There's a follow-up question, sorry, from the same user, and it's what are funding options so we can move forward to try user-centered solutions. So if I can take a stab at this, and Maia, feel free to jump in here. innovation spurs when things are constrained. It definitely, people find ways to do things that they need to get done in more constrained environments. And this sets up a constrained environment. So I think researching user-centered design, that's a free approach. That's something you can do for free if you have, that's assuming you have time. But I think one of the great things about this challenge is if you're looking for a funding source, this challenge would be a funding source. And exercising user-centered design practices now would allow you to start learning about what those digital solutions could be so that you could submit a solution to the challenge. And because the solutions right now are just ideas, we're asking for folks' proposals for what they would like to do if they were to enter phase 2 and got some of the prize money. So that would be your funding. So I would propose learning about user-centered design, learning about lean project startup, and finding ways to talk to patients or providers or whomever it is you'd like to solve your problems for, and start mocking up solutions in low resolution ways. Maia or anyone else, do you have anything you want to add? Okay. Next question was, can we submit as an individual and or organization? Yes, you can submit as an individual or you can submit as an organization. Both are acceptable. Please do check the website for the eligibility requirements for both, because this is an America Competes Act challenge. There are requirements for things like being a U.S. citizen or a U.S.-based entity. If you're submitting as an organization. So please do make sure that you comply with those, but both individuals and organizations are eligible. Next question, will the patients only be receiving data or will there be two-way communication between the patient and the hospital? So Priscilla, this one seems to be aligned more with, I guess, envisioning a solution. So will patients only be receiving data or will there be two-way communication between the patient and hospital?
Thanks for the question. In considering the user-centered design and the interaction with people with multiple chronic conditions in formulating the solution, I would expect that in the process of the user-centered design empathize phase that solvers would need to communicate with patients about what they would like to have in a solution.
Okay. Contact between the healthcare provider and the app. So the next question is there contact between the healthcare provider and the app? I think there's a couple assumptions in that, if I may. AHRQ is opening this up for solutions. We don't know yet what the solutions that get submitted are going to be. A lot of them may be apps, but we don't want to assume that they will definitely be apps. And they may interact with a provider. It depends on the problem, the part of the problem that you would like to solve and focus on. And so it's certainly possible that this could be a provider app interaction that's happening, but it could also be patient app or between both or all three. Okay. So next question, a work plan on how you would build out the proposed tool if selected as a semifinalist for phase 2. So that's quoted from the webinar. Is this referencing the architecture and coding language? I would say if you were choosing one of the two, it would be more on the architecture side than the coding language. And that's given purely because you have only 5 pages. You do have the ability to submit appendices, so architectural diagrams. System architectures could be considered appendices, but I'm not sure if coding language is relevant unless it's talking about how that coding language molds well with FHIR and makes your solution either open source and interoperable. So that's the only way I would see the need for that. But the architecture could be important as well, as long as it addresses the evaluation criteria in some way. Next question. What are you looking for the user research plans? Not sure what part of the deck user research plans was mentioned, but I'll have to go through and look. That may be a question, and I meant to mention this. If we do run out of time on questions, we will, please make sure you submit them in the Q&A pod, and we will get answers to all of them and post them after the webinar. So that may be one that we have to look into. We have to parking lot for now. The next question for Priscilla, I believe. Is AHRQ going to help us with the recruitment of multiple chronic condition patients to gather feedback, or are we expected to do this ourselves?
Thanks for the question. The solvers in the challenge will need to work with their own unique set of users to work with the users to perform the user-centered design. So the process of empathizing, defining the problem, ideating on solutions, and prototyping has to be done by the solver with people with multiple chronic conditions.
Great. So the next question is, which FHIR fields are we looking to tie with the minimally viable product? With which FHIR specification standards are the most important to address? I think anyone else, because there's a number of people on the call that know about FHIR, feel free to jump in here. From the challenge design perspective, looking at FHIR and the vast number of resources that they have in the fields, I don't know if we can narrow it at this point. I think it comes down to an analysis of the problem that you're aiming to solve, the specific, how your solution attacks the problem, and what the relevant information that you're trying to pass is in an interoperable way, obviously. And that's how you narrow the resources that need to be used. I think it'll be solution specific, especially if your solution is perhaps going after patients with specific multiple chronic conditions. It could change. It could vary even there. But if anyone else has anything else to add, please jump in. Okay, the next question, Priscilla. If we have funding from AHRQ to test our solution, i.e. R21, are we still eligible to apply?
Let me double check the challenge statement and the inclusion and exclusion criteria. We will reply back to the person. Excellent,
thank you. Next question, are you looking to be able to build a discharge plan using FHIR on the healthcare provider side? Priscilla, feel free to jump in here. I would say that is one possible solution to this. But again, we're not assuming what the solution is. It's one of the main reasons the government is hosting a challenge. It sees a problem and it welcomes all solutions.
Yes, I would echo that we're looking for creative ways to solve the problem.
Yeah. Okay, I'm going to jump around just a little bit. I'll come back to some of these questions. How is the subspecialty care info available to these points? Patients who are who are frequently admitted. How is subspecialty care information available?
I think That's part of what this challenge is trying to solve, is that people are discharged out of the hospital and they might have specific information about what to do about the problem for which they were specifically admitted, but they might not have gotten any sort of continuity of care or care coordination to help them with their other multiple chronic conditions. So what we're looking for is solvers who will do the user-centered design with patients and families to understand what their needs are and how those could be addressed.
Right. And I would point folks to the one of the links after the interoperability slides is an app gallery of apps that are using FHIR. And you'll see there are a number of apps that make their primary goal is to make patient data available to the patient, data that the patient wouldn't normally have access to. And that's, you know, in the history of FHIR, that's one of the ways it got started, was patients need their data, give it to them as quickly as possible. And it started as just a data dump where patients could get everything, and they realized a lot of it was unusable. And then it evolved into app solutions where, okay, instead of me as the patient just taking my data, I'm going to now allow this app to take my data and present it back to me in a usable way. So that's one of the main ways that FHIR is used, and I think it's definitely one of the ways that we're looking for solutions to leverage the data. So how would you differentiate this challenge from the current funding opportunity announcement, PA 2068, improving quality of care and patient outcomes during care transitions?
Hi, it's Priscilla Novak. I believe that we also have Derek Wyatt from our digital healthcare group on the line, or also Amy Lindina. Are either of you there and would like to respond to this question?
We need to make sure that they're unmuted.
Okay.
Yeah. And they may be on the phone. While we're
I might say that from my perspective, it's different because this challenge is really about designing the solutions, and our grant funding is for research.
That's true. And just from a model perspective and a funding perspective, challenges are vastly different from grants. Grants prescribe, and a lot of times, grants prescribe what the activity is to be, whereas challenges work more iteratively to say, here's a problem that needs to be solved, who's got the best idea? We'll reward the top 5 ideas, give you a little bit of runway with some funding to test it out and scale it, and then we'll reward the winners of that. So it's a different way of going after problems that the government sees need to be solved faster. And so I think that that's a major difference, even if they're perhaps going after the same purpose, ultimately. Okay. Will you be interested in solutions that are not currently integrated into EHRs if that work will be proposed in the phase 2 work plan? Priscilla, do you have thoughts on that?
I would want to consider it further before providing a response.
Okay. I think it's interesting, and yeah, I would definitely want to consider what the phase 1 portion is, the design of this, but interesting. We certainly encourage you to apply. I think that's a good, healthy response to that. So I'm going to jump back now to a couple of these. Will the discharge data be stored within the hospital, or will we create a new server to store the data? Again, I think that's a pretty solution-specific question. It depends on what your solution is and how it needs to operate. But the biggest consideration there is privacy and security. If you're creating new servers, there's a lot of consideration that has to go into moving patient data. Okay. What is the range of health literacy topics?
Hi, this is Priscilla. So in regard to the health literacy question, I think what we're referring to is, while we have many specific resources on health literacy and improving accessibility of health information for people with limited health literacy, I don't think there's a specific topic within health literacy. I think what it really comes down to is people's ability to understand the health information that is shared with them by their healthcare team and use that information to make informed choices. I think that answers the question. There are many resources on our website, and we could include that when we send out the slides. We'll give you the link to the resources on our website. We have many good sources of toolkits, implementation guides on how to improve health literacy, and usability of health information by people with limited health literacy.
Okay, and in that same lane, Priscilla, a question was asked when talking about the varying levels of health literacy and English language proficiency. What is meant by English language proficiency? Is this referring to having an option for different languages?
Usually English language proficiency refers to how well someone can speak English or read and write, communicate in English. And so in terms of health literacy and English language proficiency, they're two separate sort of conceptual domains. But I think the sort of overarching theme that we would expect as an outcome of using user-centered design and addressing the needs of people with limited ability to speak English or limited ability to understand health information would be that there would be easy to use, the end product would have an easy to use interface that people would be able to use without extensive training or a user guide, that it would be intuitive in some ways. And also that the words that are presented to the end users are appropriate to their health conditions and easy for them to understand.
Great. So I believe there's one other question. What should be the objective of the optional video submission? Priscilla, do you have thoughts on that?
The objective of the optional video solution is to showcase the solution as well as your capacities as a solver to participate in the challenge.
Yeah. Okay. Okay. I think those are all the questions that we've received. There's still a little bit of time left. Do we want to open up now and see if people want to ask questions over the phone? If we do that, if you're possibly in a place that may have a lot of background noise, please note that you're about to be unmuted, and just mute your microphone, your phone, your device. Jen, would you mind unmuting folks? Does anyone else have any questions? Okay. This is...
Sounds like a womb.
So another question came in. Sorry, folks, could you please mute your devices? We might just have to mute everyone again. I think we just take questions through the Q&A. So another question came in: is there contact between the healthcare provider and the app? I think about this question. Oh, I'm sorry, my thing just jumped back up. Okay, I think that's all we have for questions. If you have further questions, there's an email address on the website that you can email your questions to. We will be posting the video, the recording of this webinar. We will be posting the slides for you to download in the coming days. We look forward to your submissions. I want to say a big thank you to all of our presenters today. You have a great overview of this challenge. And Priscilla, any words before we sign off here?
No, thank you to all of our presenters, and we look forward to receiving your challenge submissions or emails with additional questions, ideas for clarification. Thank you so much. Have a great day.
Thanks, everyone.